I have the distinct privilege and honor of introducing Dr. Michael Levy, I can now say from Harvard Medical School. He went down a notch. He went from Johns Hopkins to Harvard. And we won't hold it against him. And Dr. Levy and I go way back. We started medical school together at Baylor College of Medicine in Houston, Texas. And back then, he was way smarter than me, and he continues to be way smarter than me. But I did graduate before him. He took the long path, and I went a little faster. So I will always have that to hold over him, even though I admit he is a smarter man than I. So Michael has spent a career in neuroimmunology, spending time both in the basic science lab and in the clinic, and he's one of the rare individuals in the world who is an outstanding scientist, but also an incredibly compassionate, intelligent, and committed clinician to his patients. And he's going to be talking to us today about neuromyelitis optica spectrum disorder. So, Mike.
That is the nicest introduction Ben has done for me. Before I get started, I just want to get a sense of how many people here have NMO. How many? Raise your hand. NMO. Okay, a few. MOG. Where are the MOG folks? MOG squad? Okay. Transverse myelitis. Everybody else. Okay, and how many of you are here just to see Dr. Greenberg? Me too. Yeah. Okay, good. Okay, well this talk is about NMO, and as mentioned before, even if you don't have NMO, there's something to be learned from these diseases because they all share some pathology and clinical course with each other. So this is Dr. DeVick. This is how I want to introduce the disease. Dr. DeVick lived a long time ago, and in France he published the first case report of a young lady who had optic neuritis and transverse myelitis at the same time, and he proposed the name neuromyelitis optica. And then he got his graduate student to put together a series of another 16 cases or so, and it became the standard for the next 100 years for patients to refer to this phenotype, this optic neuritis transverse myelitis condition, and people would call it either DeVick's disease or neuromyelitis optica, and now more recently, neuromyelitis optica spectrum disorder, NMOSD. And if you think about how you want to divide these diseases up, if you consider MS, multiple sclerosis, as being the autoimmune disease of the central nervous system that attacks everything, optic nerve, brain, spinal cord, and transverse myelitis as being by definition confined to the spinal cord, NMO sits in between because it's mostly optic nerves and spinal cord and a little bit of brain. Over time, the definition of NMO has evolved because we start to recognize it. Back in the day when Dr. DeVick described it, he said it was just optic neuritis and transverse myelitis simultaneously. Isn't that interesting? And for the next 100 years, all these series kind of describe the same thing. Then in 1999, my colleagues at the Mayo Clinic, who were the only ones who cared about NMO at the time, the room of the patients who had NMO and the doctors who cared for NMO, that room was tiny. Could be a closet, basically. So there weren't that many people interested in the disease at the time. And they proposed a criteria that set them apart from MS, because what they recognized before anybody else is that NMO is really distinct. It's not MS. It's a different disease altogether. And so they made the pitch. They said, NMO is a distinct disease, optic neuritis, transverse myelitis, and not MS. Shortly thereafter, they discovered a blood test that could help distinguish the disease. And that really propelled the whole field forward, because it not only created a patient population that was distinct, but it also helped lead the way in terms of the science and explaining how the disease worked. That blood test is called the aquaporin-4 antibody. Before they knew that it bound aquaporin-4, they called it the NMO antibody, so you might see both of those. And now we have the MOG antibody as well, which also characterizes a subset of patients who have the optic neuritis transverse myelitis phenotype. Not sure how well this map projects, but you can see that the incidence, how many cases of optic neuritis and transverse myelitis of NMO occur around the world, is fairly uniform. I mean, it's about 1 to 4 per 100,000 people. And that's true in the United States and across the pond in Europe. And even if you look out east, where as a percentage, NMO accounts for a larger percentage of demyelinating disease, but the total number of demyelinating disease is lower out east. So it's always somewhere between 1 and 4. And the one outlier here is Martinique, which is a little, I think it's a colony, French colony in the Caribbean, where the incidence is much higher. It's 10 per 100,000. So that's kind of a hot spot that needs a good geneticist to go out there and figure that out. The typical patient population with NMO is somewhat older. So these are folk, well, I shouldn't say older, because now that I'm older than the average age, these folks are now younger. So these are, 36 to 43, or I put here 34 to 43, with the median age at 39. Okay, and most MS patients present in their 20s. Transverse myelitis may have a bimodal presentation with the teenage years in the 30s. NMO is kind of at the upper edge of that age group. And it's much, much more dominant, much more common for females to have NMO, up to 9 to 1 now. And there's an interesting influence of race. I showed you the French Martinique experience. Turns out even in the United States, African Americans are more than 3-fold overrepresented in the NMO patient population. And in the UK, where the Afro-Caribbean population is overrepresented. So there's got to be an influence of race, and we have to figure that out. Now, the course of NMO is always relapsing. When we first thought about NMO as this optic neuritis transverse myelitis, we had a few patients in there who did not relapse. And maybe they were MOG, or maybe they had some other disease. But now if you test positive for the aquaporin 4 antibody, we think of you as having the same likelihood of relapse as someone who's had 10 attacks already. If you have the aquaporin 4 antibody, you should go on preventive treatment because you're bound to have a relapse. The MOG antibody was picked out of this patient population because we found that only about 80% of patients tested positive for aquaporin 4, 75, 80. And so we thought, well, there's got to be another antibody out there. And that's how people discovered the MOG antibody, which had kind of been floated around as maybe an ADEM population or an MS population. And it turns out there's also a subset in NMO. And that was a great talk we heard before about exactly what is the pathogenesis of NMO. And it's a little bit different from the pathogenesis of NMO and MOG. They're a little bit different, even though they look the same. When a patient comes into the hospital and they can't see out of their right eye, we don't know if that's MOG or if that's aquaporin 4 NMO. It looks the same when the patient presents. But immunologically, they're very different diseases. And again, we learn from each of these diseases by comparing them to each other. And then there's a population of patients who are double seronegative. And this is very frustrating for patients because they want a diagnosis. They want to fit into a peg hole so they can qualify for trials and we can study them. But there are some patients out there who have these recurring bouts of optic neuritis and transverse myelitis, and we test them up and down, and they're still seronegative every time. Very frustrating. There may be another antibody, or it may be, as Kyle said, is sometimes they test negative, but then you test them again and they're positive. So NMO is 90% of the time optic neuritis and transverse myelitis. 90% of the time, that's what it is. Some other times, though, there are some interesting presentations. We recognize now that sometimes NMO presents with these horrible bouts of nausea, vomiting, and hiccups. And when you ask a patient about it, they'll say, oh yeah, this was terrible. 3 weeks of my life, I was in bed. I couldn't eat anything. I lost 10 pounds. And then it went away. And we now recognize that that's a unique feature of NMO and sometimes MOG. And then there's some other rare presentations of NMO that we see now that we have the aquaporin 4 antibody, we know what to call it. So to qualify for the diagnosis of NMO, it's easiest if you test positive for the aquaporin 4 antibody. In fact, if you have any inflammatory lesion in your central nervous system, I don't care if it's optic neuritis or transverse myelitis, that's the greatest chance. But if you have it anywhere and you test positive for the aquaporin 4 antibody, that's a free pass. You're done. Your diagnosis is NMO. That's how easy it is to qualify for the diagnosis now. And if you test negative, it's a bunch of head scratching and chin rubbing and putting our heads together to try to figure out what it is. But there are criteria. If you test negative, we still want to know that you have the core features, optic neuritis and transverse myelitis. And we want to see some features on the MRI that convince us that it looks like NMO and not MS or MOG or something else. So to qualify for seronegative disease is a higher bar. Now, the type of test you get has an influence on how we think about your disease. So for example, there are several different types of the NMO test. And one of them spits out a number, and that test is called the ELISA test. And it'll give you a number where it's less than 3 is negative, 3 to 5 is borderline, and greater than 5 is positive. And what the Mayo did, they didn't really like that test. So what they did is they took a bunch of patients, you could see here on the list, who tested positive by ELISA, but then they tested it with their favorite test called a cell-based assay, which they insist is much better. And then they insisted that a few patients who tested positive by ELISA, but negative on their superior test, that they don't actually have NMO. And so they want us to filter out those that may have a positive test on one assay, but negative on the other. And these cases are definitely more complicated because many of them have overlapping phenotypes. Well, do they have MS, or maybe it's MOG? And now we have 10 cases that are positive for MOG and aquaporin 4 at the same time, and what do we do with those? And all I have to say about that for today's visit is just come see me in the clinic and we'll sort it all out. You're a complicated case. For the most part, when you test positive for the aquaporin 4 antibody, we say it's 99% specific, meaning if you're positive with a lesion in your central nervous system, you're done. Your diagnosis is done. Now, when we got to these interesting cases, especially those who are seronegative, we polled a whole bunch of neurologists and we said, here's the case. Presented the case, optic neuritis or transverse myelitis, and we said, but they tested negative. So what do you think this is? Is this MS? Is this NMO? Is this MOG? Is this what? And they polled a whole bunch of doctors, and what this statistical table shows is none of us could agree on the diagnosis. And so I think most of you figure that out, right? You go to one doctor and he says, oh, this is definitely NMO. And then you go to another doctor, he says, I don't think this is NMO at all. And then you go to a third doctor and they may have a third opinion. And you keep racking up all these opinions. And the problem is that we really are dependent on that blood test. So, as we continue doing research in this field, it's really important to promote these blood tests and to discover new biomarkers that can help make the diagnosis. This is a diagram of how we think NMO happens. Let's see if this mouse works. Yeah. Do you guys see the arrow? Does it show up? Yeah. So everything starts in the bloodstream. Even though the attack ends up in the optic nerve and the spinal cord, everything begins in the bloodstream when your immune cells conspire to attack. The T cells talk to the B cells, and they decide, okay, you know what, guys? Aquaporin 4, we don't like it. We think aquaporin 4 is foreign. Of course, it's not foreign to your body. You were born with it, but for whatever reason, your immune cells say, you know what, we want to get rid of it. Let's go surveil for it. And they go surveilling in the central nervous system, and they say, wow, optic nerve and spinal cord, they sure have a lot of aquaporin 4, and we think it's foreign, so let's mount an attack. And so the first thing they do is they recruit the rest of the immune system to break down the barrier between the blood and the nervous system, and they invite everybody in. And they lead the attack, they lead the charge, they recruit these cells called neutrophils, which basically just spill their guts onto your spinal cord and in your optic nerve, and it just breaks the tissue down. And then the antibodies, aquaporin 4 antibodies, they get in there too, and they fix this system called the complement system to continue that breakdown process, and what you're left with is a lot of damage. So that's how this process occurs. But remember, it all starts far upstream with the cellular nervous system up here, a cellular immune system back here. But when you look at this whole pathway, you can imagine there are several potential targets for treating this disease. You can go after the cells themselves, far upstream, and tell them, you know what? Alkaporin 4 is not foreign. That's what we do in our lab. That's called tolerization. That's re-educating the immune system to correct its mistake from the top. Or you can just remove one of those cells, like the B cells. You'll be hearing from a company that took this strategy. Just get rid of the B cells. So if the T cells have no one to talk to, they can't mount an immune response. Or what if you just disrupt their communication? There's another company that said, hey, we can just block the communication between T cells and B cells, and maybe that'll work. And you'll hear, I think you'll hear, actually, I will present some of that data later today. And then another company said, well, what if you just let the T cells and the B cells do their thing, but you just block all the damage? So let the immune system do what it wants to do, but if you block all the damage, maybe you'll come out okay. So they took that approach, and you'll hear some of that data as well. And there are many different approaches you can continue to take here. When the immune system decides to breach into the nervous system, you have a little bit of time, not a lot of time. I always tell my patients, call me at your first symptom. Because time is cord, time is eyes, time is optic nerves. Every day that goes by, the immune system causes more and more damage. Now, at first, we think that the damage is reversible. We think it's just a little bit of swelling, and if you treat it in time, you can reduce the swelling and everything can heal a little bit better. But the more time that passes and the more parts of the immune system are recruited and the more complement is fixed, the more damage you get and the more permanent it is. And then you get demyelination and then the nerves start to die and all the supportive cells are gone and the worse it is. And there's good data to support this concept. So the earlier you treat, the better. Now there's one piece of good news about NMO. It's my favorite part of my favorite slide. The good news with NMO is that if you stop the attacks, you'll never be worse than you are at the time. Because all of the disability from NMO comes from attacks. There's none of this. I don't know if you have friends with MS who are doing everything they need to do and they do it right, but they still get worse over time and they end up in a wheelchair even though there are no new attacks. That's MS. That's a very different disease. So with MS, this big blue triangle here, they continue to get worse even when you stop the attacks. It's really frustrating to them. But with NMO, the piece of good news is we don't have that problem. If you stop the attacks, you stop the degeneration. The bad news with NMO is with every attack, you accumulate more and more disability. So we really have to focus on the prevention. We also need to focus on the recovery aspect. That's an area of unmet need. So if you see a pharma person around here, and there's a couple in the audience, tell them, hey, now we have preventive medications for NMO, focus on recovery. We need medications to improve outcomes, to induce regeneration and restoration of function. Because that's really something that's missing in MS, missing in NMO, missing in TM, missing everywhere. And this is what I'm talking about. With NMO, with every attack, you accumulate disability. So what does that look like in the end? 34% have either an arm that's not working or legs that aren't working. And we consider that permanent because it's six months out, 1 year out, and they're not making any more recovery. 23% are wheelchair dependent. 18% are visually impaired in both eyes, and right now about 50% of our patients are visually impaired in one eye. Now you may say, well, you have the other eye, but it still limits your function in life. It's hard to catch a basketball with just one eye. And our mortality rate is dropping. It used to be 32% in 1999. It's 9% on this slide. We just did a more recent study. Now it's 7%. So we are making progress. That's to be applauded, but you don't have to applaud. But it's a good thing, but we can do better. Now the MRIs in MS and NMO are really distinct. And if you come to my clinic, one of the first things I do is I shake your hand, and then I say, can I have your MRI, please? And you hand me the disc, and I put it in the computer, and we pull it up. Because I really want to see what your spinal cord looks like on the MRI. And this is what we're looking for. On the left side here, this is an NMO patient, and they're looking to this side. Here's their front, here's their back. The spinal cord is this gray thing here. And the white thing that's interrupting the gray is the lesion. And it's long. It's long because you can count it against the vertebral bones here. These squares are your vertebrae. And if it extends more than 3 segments, we call that longitudinally extensive. And that helps distinguish NMO from MS. You can see on the other side here, that little white dot that the MS patient is complaining about, it causes some disability, but it's much, much smaller than NMO lesions. So these NMO lesions are large, they're destructive, they're disabling. In MS, they can accumulate and become disabling over time. But when they occur one at a time, each attack is not as disabling as NMO. In the optic nerves, the lesions are also long. In this cut I'm showing you here are the eyes. You can see those 2 black balls there are the eyes. And the nerves connect the eyes to the brain. And right here, this white line here, that's a long inflammatory process that's disrupting all those nerves from carrying the visual signal to the brain. And in MS, you're not the only one who can barely see it. That little white dot, that's it. So MS lesions, again, they're smaller and they can accumulate over time and be disabling, but at the time of the attack, an NMO lesion causes much, much more disability than MS. In the brain, they also look very different. This is a pattern that all even medical students now, can recognize from across the room as being MS. See that brain here? These little white lines here have a classic look to them, and we expect our fellows to recognize it. In an NMO, there's no real look. It's just big, bad, and ugly. You see these white areas here? These are areas of destruction in the brain. So the brain is usually spared in NMO, that's good, but when it does attack, the lesions are ugly. Okay, so I'm going to mention a little bit about the treatment. I have 4.5 minutes. I'm going to divide them into acute and preventive. Acute is what you think it is, putting out the fire. There's an inflammatory process going on, it's causing damage, and we need to stop the damage. Preventive is, can we stop the immune process farther upstream and prevent it from causing an attack in the first place? On the acute side, my colleagues in Germany have demonstrated that plasma exchange is great. Okay? Plasma exchange really works, but you got to do it quickly. What I'm showing here is everybody who got plasma exchange within a day of their onset of symptoms, half of them recovered back to complete baseline, complete recovery, if you started plasma exchange within a day. Now, that's really hard to do. Both at the Harvard hospitals and Johns Hopkins, probably it would take at least a day or 2 to get plasma exchange started. But in Germany, they got this thing down pat. If you get it within 2 to 5 days, you still have a very good chance of good recovery. But if you wait 3 weeks and then you get plasma exchange, look, you have less than a 5% chance of making a complete recovery. All right, but what about incomplete recovery? The blue folks here are good recovery. And you can see here, if you start plasma exchange soon, within a day, of course you have great recovery. Even if you start it within a week, more than half have a good recovery. So if you're in a wheelchair and you get plasma exchange within a week, chances are decent that we'll get you up with a walker by the end of that 6-month recovery period. So plasma exchange, that's what I want to emphasize here for acute relapses. What about on the preventive side? Well, my FDA colleagues cringe when I bring up this slide because all of these studies were done without a placebo control and without being blinded. So you have to take this with a grain of salt. But if you look at all of the different observational studies that have been done in NMO, if you suppress the immune system, you do better. And you can suppress it with azathioprine, Cellcept. Azathioprine is also known as Imuran, Cellcept, rituximab, methotrexate, you name it. If you suppress the immune system, you do better. You prevent relapses in NMO. Now, there are varying degrees of success. On this graph, on this chart here, we tabled the success rate of Imuran, azathioprine, compared to rituximab. And with azathioprine, you have about a 50-50 chance of staying in remission as long as you're on the treatment. With rituximab, if you do rituximab right, you have only a 17% chance of failing. That's an 83% chance of success. And I would tout these numbers in clinic because I felt pretty strongly about it, even though we didn't have placebo-controlled data to support it. But now we have some placebo-controlled data. I'm going to show you a couple of these slides. I mentioned the 3 targets. The first target I'm going to present is, I believe the first target I'm going to present is where eculizumab blocks, which is complement. So complement is a destructive process. If you block the bullets from hitting its target, maybe you'll prevent any damage from that bullet. Complement is like the bullets. So if we can block the complement system, maybe we can improve outcomes. I'll show you that data. Inebilizumab depletes B cells like rituximab, but a little bit broader. So if you get rid of the B cells, you get rid of some of the plasmablasts and other cells participating in the process, can you improve outcomes? I'll show you some data. And then with satralizumab, I lost my mouse. With satralizumab, you're blocking communication. I'll show you some of that data. Now, I'm going to try to compare these studies, but they're not fairly comparable, okay? Because all the studies were done slightly different. First of all, they're targeting different things. Some are IV, some are subcutaneous. They have different dosing schedules. Here are the names of the different trials. They're not exactly comparable. It's not apples to apples to apples. It's like oranges and apples and peaches. So all fruits in the same basket, but I'm going to compare them for you. Okay, eculizumab, blocking complement. What this graph shows is that every time a patient relapses, it drops a notch. You can see eculizumab didn't drop many notches. In fact, it only dropped 3 times out of 96 patients. So 3 out of 96 had a relapse. That's pretty good. That's a reduction in risk of relapse of 94% compared to the placebo group. So this was placebo-controlled, and many of these patients were on Cellcept and other things, and they still relapsed. But if they were on eculizumab, very, very strong prevention. Satralizumab blocks communication between cells. Same type of thing. Every time a patient in the treatment arm drops here, it's a relapse. So you can see there's a few more relapses. But what satralizumab did that eculizumab did not is they included the patients who did not test positive for aquaportin 4. And as I mentioned, these could be MOG, it could be doubles. We don't really know who these patients were. If you take those out, satralizumab looks pretty good, almost like eculizumab, with just 3 drops among 30 patients. So if you take those patients out and only include those who are aquaportin 4 seropositive, satralizumab looks pretty good, and their reduction in relapse risk is 72%. Pretty good. What about inebilizumab? Inebilizumab also included some seronegative patients, so that's the total population here on the right. If you include only those who are seropositive, pretty good. Again, just a few drops in the treatment arm and a lot of drops in the placebo arm. Total reduction in relapse risk is 70-some%. Very, very good. These numbers mirror rituximab fairly well. So for those of you on rituximab and you're happy, this is the new, better, proven form of rituximab. So here are the takeaway points. NMO and MOG, very different from MS. Long lesions on MRI really help us to distinguish these two diseases. The aquaportin 4 antibodies are golden. If you tested positive, we love it. Makes our job a lot easier. MOG antibodies, we're just as happy with those now. Really help predict your future. Acute treatment, plasma exchange, plasma exchange, plasma exchange, plasma exchange. And prevention, there are a lot of treatment options coming up. You'll hear from some of the pharma reps later today about their preferred mechanism. And if you ask me, I can tell you what I think each patient population would deserve with each of these drugs. But the summary is they work very well. These are my kids. They've only grown a year since this picture, and I'd like to thank everyone in the lab for their help. Do we have time for, no time for one question? That hand went up first.
You mentioned potential other biomarkers. Are there other tests for additional antibodies in the pipeline?
Yes, there are. My colleagues at the Mayo Clinic tell me that they have 15 additional biomarkers in the works that they are validating. Many of these are in the context of cancer, some are in the context of autoimmune disease. It takes a lot of work to make sure that the antibody fits the disease. So I'm trying to be patient with them and not bug them for the data, but yes, there are many to come. All right, thank you, everyone.